Good day and welcome to the Pomerantz Mentor, sponsored by ProScan MRI Education Foundation. And today's vignette will focus on the sequences for imaging the wrist. Now these sequences will also apply generally to other articular spaces, the knee, the foot, the elbow, and so on. So let's get right to it. Let's look at one of the weaker sequences. It looks like a T1 or fat-weighted image, but how do we know it's not? Because this water-containing area on a T1 weighted image should be dark, like urine, like bile, like aqueous humor, like any water-containing structure in the body, such as cerebrospinal fluid, but it's more gray. A long TR and a short TE characterize this sequence. It's very good anatomically. It's very good in terms of the overall signal that it gives you. It looks like a T1 weighted image, which can be a real problem, pitfall, and fooler for a clinician that's looking at their own images. But once you realize that the TR is above 600 or 700, you should be dialed in that you're looking at a proton density sequence, which is very insensitive to look at the cancellous bone or marrow. But layer on top of that the spectrally specific inversion recovery pulse. You now have a fat-suppressed proton density image that has very good signal to noise, but excellent contrast resolution. The workhorse sequence, the versatile sequence to evaluate any articular space. And suddenly, without warning, our little mass becomes white. And our lunate, which looked relatively innocuous, now demonstrates a relatively confluent area of edema. Perhaps you recognized it on the PD, but much more easily seen when you add the fat suppression, and the rest of the bones are gray, and the lunate looks a lot different. Here's another example of the proton density fat suppression sequence known as PD spur at work on a high-field scanner. And what defines a high-field scanner? Anything from about 0.7 to 1 Tesla and above. Now, this patient got struck with a lacrosse stick, even though he was wearing gloves. He had an x-ray in the office, which was normal. This happens 50% of the time because 50% of all fractures in the wrist are going to be intramedullary cancellous bone and endosteal bone injuries. This one is a crack. It's a microtrabecular fracture inside the wrist that goes up to the cortex but doesn't penetrate it. There's no step-off. You won't see this on a radiograph, but it is so easy to identify both the crack and the surrounding edema on the all-sensitive, all-knowing, versatile proton density fat suppression sequence known as PD spur. Now at Lowfield, again, much maligned, but excellent when looking at extremities and orthopedic MRI. The image isn't as pretty. The signal isn't as robust, but the contrast resolution using this particular type of fat suppression known as STIR does just as good a job. This time we have a microtrabecular fracture running horizontally through the lunate. Everyone and anyone can see that signal interruption. The overall contrast resolution is superb. The spatial resolution, not quite as good as at high field. The type of fat suppression, a little bit different. If you're a clinician, how do you know it's fat suppression? You look at the fat. The blacker the fat, the better and the more sensitive the overall sequence. Just look at the bones. The blacker the bones, the more sensitive you'll be in picking up water signal intensity. Now let's take two sequences that are a little bit alike yet different. One is called the T1 spin echo, a heavily fat-emphasized sequence. The fat is white. The water is difficult to identify. It's intermediate to low in signal depending upon whether it's pure bulk phase water or proteinaceous fluid. The fracture, though, is easy to see, going across the mid to distal pole of the scaphoid. The T1 weighted image, while very sensitive in picking up cancellous bone abnormalities, has its greatest strength in its specificity, in characterizing the severity of that bone injury. On the other hand, a T1-like gradient echo image, also known as the spoiled gradient echo or the incoherent gradient echo, when acquired with thin sections, it too shows the crack, but not with nearly the same ease as the conventional T1 weighted image. So in other words, this is not a sequence we use routinely for evaluation of the marrow. There is a little twist to it that we'll discuss a little later on that can emphasize the marrow, and this is known as out-of-phase gradient echo imaging. But that's a story for another day. What is the value of this sequence? Looking at the hyaline cartilage, this gray stripe between the greater multangular or trapezium and the base of the first metacarpal. So this, more of an articular sequence, more of a cartilage sequence, a high-resolution sequence, but not a strong medullary bone sequence. Let's have a look at two different types of water-weighted gradient echo images. These are water-emphasized because when you look at the joint fluid, it's white on both of these sequences. What differentiates them? Well, one is three-dimensionally acquired as a volume, and then that volume is divided up into very, very thin slices. So this has higher spatial detail. This has less spatial detail. Each slice is acquired before you get to the other slices. It's not acquired as a volume. Yet they both do an excellent job at showing you the triangulofibrocartilage with its radial attachment, the central portion of the triangulofibrocartilage, the lunato-triquetral ligament, the peripheral attachments to the fovea and styloid, and to the fovea and styloid a little bit off the image, but definitely seen. Both do a pretty good job at showing you the articular spaces. In this example, the patient has developed a small chronic pseudocyst due to inflammation and microtrauma or friction at the scapholunate interval. So what's the major difference between a 3D gradient echo and a 2D? The 3D, higher spatial resolution, not quite as good contrast resolution. The 2D, which can be done on any scanner, especially at low field, very, very good contrast resolution, but not as good spatial resolution as the volumetric acquired 3D dataset. Now, very often, when I'm looking at a scan, I try and string the studies together, especially in the coronal plane, which is my favorite initiating plane for evaluation. I put together a 3D gradient echo, a T1, and a PD spur. The 3D gradient echo is there for evaluation of the cartilage. It's also excellent at evaluating the articular space and looking for loose bodies and the presence of hemosiderin or blood. In this case, we have none. It doesn't do a very good job, though, in the medullary space where it misses an erosion in the capitate. It misses, or almost misses, an erosion at the base of the scaphoid. But it does do a pretty good job at showing you the scapholunate membranous portion of the scapholunate ligament. It's a little gray. There's some signal inside it. This is membranous degeneration of the scapholunate link. We see a much more robust lunato-triquetral ligament with a small slit of high signal intensity inside, which is common, but a smooth interface between the lunate and the triquetrum. Not so over here, where there's a ragged, ill-defined interface telling us we have inflammation, synovial proliferation, and cartilaginous irregularity. Next, we hop over to the T1 weighted image, where the real strength is in its specificity in identifying medullary, cancellous, or endosteal bone abnormalities, an erosion in the capitate, surrounding areas of edema in the capitate, an erosion in the base of the scaphoid. It does a reasonable job at looking at the triangulofibrocartilage, but It does a reasonable job at looking at the triangulofibrocartilage, but perhaps not as good as the gradient echo image, which is a little bit thinner and does a very good job with fibrocartilage. It shows a small area of inflammation and injury along the base of the TFC disc. Then finally, off to the right, our sequence that ties it all together. The versatile sequence, the sensitive sequence, the proton density fat suppression. How do we know it's fat suppressed? We look at the fat. Look at the hamate. It's nearly black. It's a beauty. In other words, it's going to be highly sensitive for the opposite of fat, which is water. Water in the bone as edema. Water in the erosion, which is undergoing cystic degeneration at the base of the capitate. Water at the base of the scaphoid, where pseudocyst formation is occurring. Swelling in the scapholunate interval, where membranous degeneration of the scapholunate ligament is occurring. And a very different appearance to this interface when compared with the lunato-triquetral interval, which is not swollen and is smoother and is grayer, and you can see a thin slit of the joint space between the two. That slit is obliterated or lost at this site of micro-movement or micro-instability. And finally, the triangulofibrocartilage disc is exquisitely visualized, and one sees a signal that goes down and then comes back up as a chronic triangulofibrocartilage tear that is visible on the T1 and is visible on the 3D gradient echo, but is highlighted a little bit better on these two. So cartilage, hyaline cartilage, fibrocartilage, spatial resolution, ligamentous evaluation, but not very strong for the medullary bone. Very strong for the medullary bone, not only in detection, but especially in characterization. And finally, an all-purpose sequence with great sensitivity. Fat suppression making fat black, making water white. You'll be able to assess just how sensitive an image you have by simply looking at a fatty structure and seeing how black it is. The blacker it is, the more sensitive a scan you have in your hand. Thanks and have a great day.